some questions coming to me around the world, people asking me about some things, about some topics, and all those topics, they have this importance, this clinical importance, as I say. And we will start with the Brecht bonding, go into alignment and leveling. And about this topic, alignment and leveling, I'm gonna cut everything that doesn't matter for us, and we are going directly to the points that we do during alignment and leveling to overcome the problems of this stage of treatment, okay? And then go into canine retraction, the problems that are generated in this part of the treatment, space closure phase, which is very, very difficult actually using any of the brackets, prescriptions, and ways of treating aligners and everything. We know this is the most important, most challenging part of orthodontic treatment, and we have to do many times since we treat many class 2 cases. So several class 2 cases are blocked during the retraction because we don't manage, okay, this kind of biomechanics during retraction. So I hope to show to you ways to overcome those problems during this class. And so at the end of our class, we're going to deal with a topic that is very interesting also, because we have to choose what we have to do, what's the best way, what are the best ways to deal with space, remaining space that we need to close or open, and some mechanics. Of course, we don't have time to do all the mechanics of molar uprighting, because for that we would need 8 hours, another 8-hour class for that, because we have to deal with the biomechanics, we have to deal with the pros and cons and each biomechanic, with each biomechanic that we use, and we have to put in the field to understand it. The periodontal status of the malocclusion, we have to put the occlusion itself. So there are many ways to deal with that, but I hope to clarify some of the choosing that we have, some of the ways to deal with that space closing or opening in those remaining space that we have in our occlusion. So those are the topics. Those 5 topics are going to be shown here separately, and we're going to start with bonding in orthodontics, which seems to be very simple. We do that almost mechanically, but we have some ways to view the problems, to deal with the problems before they appear, deal with the problem, the potential problems that can rise in this part of the treatment, and we dealing with that, we avoid its appearance. At least we avoid that it causes a lot of trouble for us during the treatment, during the rest of the treatment. So we have some topics to discuss here. One of those is the centralization of the bracts and tubes, and differences that we can put in our treatment in class 2 and class 3 cases. When we decentralize the position of the bracket, some situations can help us, okay? In some situations, it's allowed, okay? That's what I mean. In some teeth, specific teeth. The height and angulation should be carefully checked, and I'm going to show you why. Change bracket height in special cases, we can do that, yes, but we have to understand what happens when we do that. Change angulation in special cases, okay, it's very important also. And avoid excess is something that we do, or sometimes we don't do because we don't pay enough attention for that, and we have some insets that are embedded in this kind of situation. So let's begin with the start. Let's start with the beginning of our positioning of brackets. Centralization of the brackets is important, especially in anterior segment of the arch. We do the centralization in order to balance the position of the tooth, and in order to not to do rotations, because when we go out of the center of the incisor, for example, especially large incisors as the central incisors, upper central incisors, so sometimes we have this outcome. Sometimes we have the rotation of that central incisor that we can deal with the rebonding of the bracket. Of course we do, we can, or just adding bands at the arch wire, the leveling and the leveling arch wire, in order to correct the rotation. So we have those two possibilities. We can either rebond, or we do the new bend, do a bend in order to correct that, which I prefer to do. And I'm going to show you why I do that in most of my cases. Sometimes I put in my social media, sometimes I put these cases in Instagram and Facebook, and I have groups in WhatsApp, and people also ask me, why not just rebond? I consider a possibility of rebonding brackets. Yes, it's important. It's another possibility for us. But one thing that we have to keep in mind is that we need to have tools in our practice in order to achieve a better speed treatment, because we don't have to go back in our arch wire sequence. For example, if you notice that you have this kind of bad positioning, as you can see here in a rectangular arch wire, and then you go to do the rebonding, and then you decide that rebonding is the best thing for that patient. What you are going to do? You put the bracket in the right position, or you put bracket in a different position in order to overcorrect it. I don't know. It's possible. Either possibilities are possible. So are the possibilities you can do. So if you do that, you have to go back in your arch wire sequence. You have to go back to round wire, to not stiff round wire, but soft round wires, in order to correct that softly, because this is what you want to do. So you have to run the sequence again till you reach that position, that sequence, that part of the sequence that you were before, rectangular arch wire. So when we do that, in this case, for example, we don't need to go back in this sequence of arch wires. So we are speeding the treatment when we do bonding, when we do bends. When we do bends, we don't need to go back. We go forward. We go with another arch wire, and the next time when your patient come back to the next visit, we change for a stiffer arch wire. And when the corrector, when the tooth is corrected, or the group of teeth that we are dealing with is corrected, we have either possibility of rebonding, now with a stiff arch wire in a passive position, meaning I don't need to go back in the sequence, because I can put in position a stiffer arch wire, for example, a 1925 stainless steel, of course, in using a combination of a slot 2230, of course, so a 1925, using this position of the arch wire, the passive arch wire, to place the bracket in the right position. This is one possibility. Or we can go with the sequence of the arch wire, keeping the bends or increasing the bends if it is necessary, but not with the need of going back. So it can speed in the treatment. That's important for me. I almost never do the rebonding of the bracket just to correct one position. I do the rebonding of the bracket when I have that tooth corrected, and after that, I don't want to do bends and bends in the sequence of arch wires, because sometimes we need to do torque, sometimes we need to do other bends to do the perfect positioning or almost perfect positioning of our teeth. So if we have many bends in our arch wire, it may be difficult for us to deal with. So sometimes we do that, correct that position of teeth or tooth, and then we go rebonding in a passive position with a stiffer arch wire. This is what I do. So this is what I wanted to explain, because we will see during our alignment and leveling phase that I'm going to do that much. Okay, so we can do the correctioning. We can correct the positioning of our tooth. This is other thing that we see a lot, especially in our post-graduation programs, because we know that to understand the bonding, to do the bonding, I'm talking about the direct bonding here. We can, of course, we can do indirect bonding. It's another possibility. Yes, it is. But with time, I really don't think you are going to do that in your practice unless you have a big clinic with lots of employees, and this is something that can be applied in this situation. But you don't have it. If you use your practice in a private clinic and you are one person seeing all the patients, it's not that easy to do that. I think you keep you have many things to do. So it's one more thing to consider. So when you go in your sequence of learning, you are learning more and more and more, and at some point you see that you can do that without the need of positioning those brackets in an indirect way. Okay, so this is what I think, at least. And here we see in our post-graduation program many students doing that, because they are sometimes afraid of doing the squeezing of the bracket in order to remove the excess of the composite. So sometimes they leave this kind of composite in one part of the base of the bracket base, and it will work as an inset band, because we have now a thicker base that will pull this part of the tooth inwards. So this is something that happens a lot, and sometimes we are just able to see that, to notice that when we reach stiffer arch wires, like a rectangular arch wire, for example. So we have to deal with that also. Apart of the centralization of the incisors, sometimes we need to deal with the class 2 and class 3 cases to correct the positioning of those cusps. We can change a little bit the positioning of the brackets, decentralizing it. So sometimes it can help us, because when we centralize, we know that the cusps are going to be even, are going to be completely perpendicular to the arch wire. But when we change it, when we change the positioning of the bracket, for example, in a class 2 case, which is very common for us, what can we do to help us to correct and to increase and to facilitate the intercuspation at the end of treatment? What do we want when we are treating a class 2? For example, a mild class 2, like 1/3 of class 2, comparing the position of the premolars. So we have approximately 2.5 millimeters of sagittal error. And if we do this, that I do frequently, if we position the bracket a little bit more mesial, if we flee for that position, if we escape from that position of the center of the crown, and you go a little bit mesial, what are we doing to the class 2 patients in the upper arch, of course? And we don't need to do that in the lower arch, because of the anatomy of the premolars in the lower arch. They won't help a lot, but in the upper arch they will help. So when we go a little bit for moving our brackets mesially, we are going to rotate a little bit those crowns distally. The tip of the crown is going to be positioned a little bit distally. So this is something that I've been doing for a long time now. I learned from Professor McNamara in a course that we gave together some years ago, and that's something that I'm using a lot, and it's in his book also. Okay, so we see that when we do that, we can rotate a little bit that teeth, that set of teeth, the premolars, and they go distally, and it will help the adjustment. It will help the intercuspation, especially in the second premolar, which is a very variable, which has a very variable anatomy. Okay, this is something that helps us in settling those cusps. Okay, and here we have, as you can see, those brackets are a little bit positioned more mesial in both segments here, and it helps a lot in cases when we want to do this beautiful intercuspation, as you can see here. So now we have this beautiful and this solid intercuspation, and this is something that can be achieved easily, not easily, but a little bit easier when we do this positioning a little bit mesial when it's a class 2. When it's a class 3, of course, is quite the opposite. We go distal in our positioning of premolar brackets, and they will rotate mesially. So those situations help us when we're treating mild class 2 or mild class 3 cases, and helps in adjusting the cusps, the position in the intercuspation at the end of treatment. So believe me, you will facilitate your intecusation doing this kind of procedure here. For the positioning of lower canine bracts, I always do this. Always do that because it's something that is very common, that you don't tackle the companies that sell us the bracts. They have in the base of the bracts more thicker bases, thinner bases, according to the position and the thickness of the teeth, the tooth, and